like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is fast, free, and fun, the Perfect EHR. Dr. Dan, how are you doing tonight?
I'm doing great, Faisel. It's good to be here with you.
Great to have you. Good to be here. Dr. Dan is co-host and moderator of the chat room. Robert couldn't join us tonight. We're hoping when we make the switch to Tuesday evenings that it'll be better for Robert to join us. Robert, it's not the same without you. Look forward to having you back on as soon as possible. Well, I'm very excited about tonight's friend. Tonight's friend is Dr. Uli Chettipally. Dr. Chettipally, welcome.
Thank you, Faisel and Dan. It's great to be here.
Before we went live, we were talking about our concerns about the cold weather in Florida. It's supposed to be dropping way down into like the mid to upper 60s tonight. We're very stressed out and worried about Easter weekend, the negative impact of Easter weekend here in Florida. And how's everything in California?
Not too bad, not too bad. Right now it is 78 and warm and sunny at 5 p.m. So looking forward to the weekend.
Wonderful. Well, Dr. Chettipally, I have been looking forward to talking with you about this topic. Most of us spent the best years of our lives, and where you couldn't make people feel better, at least to reduce suffering whenever possible. So we go through residency. Now we're all board certified, ready to make this world a better place, one person at a time. And then instead, most doctors end up in the fee-for-service healthcare system. 95%, regardless of which EHR system that they're dealing with. And so, Dr. Chettipally, most primary care doctors agree that with the benefits of having an electronic health record system, despite all the improvements with the different systems over the last 10, 15 years, why do most of us still feel like EHRs need a complete overhaul?
Well, Faisal, this is a great topic, very near and dear to me. When you talk about fee-for-service, fee-for-service system is like, I say, it's like being on a treadmill with somebody else controlling the knobs. So imagine, you're doing your thing, you get used to the rhythm, and suddenly somebody changes the speed. Hey, you got to work harder to make the same amount of money. The joke aside, it is a very stressful situation for physicians. In fact, 50% or more than 50% of the physicians are feeling burnout. And a big factor is the EHR. They call it EHR, but actually it's much more than that. It's the whole business model that makes EHR such a painful thing. And so, I'm really excited and curious and trying to find out, what would be the best way to make a physician's job easier. I think at the bottom line is they should not be documenting just to get paid. I think that is where I think the biggest problem arises. And I'm really glad ChenMed believes in that, and also that when physicians put out their best care, the compassion and also the connection with the patient, that's when you get the best outcomes, not by documenting in an EHR. So
Do you think that that's what's driving most of the burnout? I attended a conference where someone said that it's, the patients are just too medically complex. Medical complexity is driving the burnout.
Yeah, I mean, I don't think doctors are worried about, complex patients. I think so. If you think about EHR, is that a symptom of a disease or is that the real disease? Right? When you look at medical terms. I think it's a symptom of a disease. I'm sure you guys know at ChenMed, your practice is very different because you're not getting paid by how well you document or how many boxes you check. And so that I think it's that what some people have called it as moral injury that happens when you're forced to do something that you really think is not worth anything. So you're forced to do things just to get paid, although you know that that's not going to make a big difference for the patient's care, right? While they're seeing the patient. Although there is a big benefit if you are able to capture the data, if you're able to analyze it on the back end and be able to provide information to the physician while they're seeing the patient. So if you can create a decision support based on all the data that has been collected, that's valuable. That's when an EHR becomes smart and decreases the workload for the physicians and hopefully improve the outcomes for the patient also.
I have to agree with you. I'm sorry, Dr. Dan.
No, I was just going to say, so the interesting thing to me, I don't know how experienced you are with AI, but I'm almost wondering, we hear all these stories about Siri listening to us when we're talking in our houses. Couldn't a computer be listening to what's happening in the visit and be pulling out what needs to be documented rather than the doctor actually having to function as their own transcriptionist or data entry operator? And I'm wondering if AI would actually figure out, it might pull things out that we don't recognize as well. So what are your thoughts about that?
Well, you asked the right person here. I wrote the book on AI. It's called Punish the Machine, The Promise of Artificial Intelligence in Healthcare. Yes, the machine should be doing a lot of the work, and they're very good at it. Now, the question is, how much of documentation do we really need? And are we documenting the things that will actually make a difference in a patient's outcomes? For example, we all write, heart exam, S1, S2 heart. Does that really matter? I think I don't remember ever documenting anything other than S1, S2 heart in a heart exam over the past 25 years of my practice. So that is a totally useless piece of information. Of course, the patient is alive and okay. So what else? What other data points are actually really critical for the care of the patient in front of you? How will that documentation how will that documentation help the outcome for the patient? That's exactly what I'm looking at is, do we really need all these 120 data points, or do we need these 30, which are very critical for this specific type of patient? That's where AI comes in and can figure that out, what exactly needs to be documented.
It's interesting when you said earlier that, the EHR may just be a symptom of a bigger issue. And it would be interesting to see what would have developed in models that were not fee for service. Like when we were meeting doctors in the direct primary care world, we're meeting full risk doctors who are outside of the fee for service system. It would be interesting to see EHRs that were developed specifically for doctors who are outside of the fee for service world. It would be like in our we have an in-house EHR that's designed for the full risk model.
Yeah.
But I wonder what would have happened if the marketplace had EHR companies designing these systems that weren't designed, the purpose wasn't to generate more revenue by billing.
Yeah, and one thing is that, you know, so let's say a DPC model or a full risk model, right? The physicians need to decide what should go into the EHR and what is not needed, right? You know, you cannot have a standard template and say you have to click these, 23 boxes and expect that, care somehow is better, right? And plus, it could be, 20 data points or 30 data points, or it could change based on the type of patient you're seeing. And it could change with time, right? We've done studies at Kaiser Permanente, when I was there, where we looked at how do you risk stratify chest pain, right? Actually, the paper just came out yesterday or day before yesterday.
Oh, wow. Congratulations.
Thank you. So, we have, in the emergency department, we follow these heart scores and EDAC scores and things like that to assess, what are the chances of this person having a heart attack in the next 7 days, 30 days, 60 days, right? Well, those are just a handful of variables in there. And when you use that, it works, but it's not the best. You could do a lot better if you just went back. What we did was we went back and looked at 100,000 patients that came in with chest pain and see what happened to them. How do these risk scores work there, right? What we found was that if the system that we used using machine learning to figure out what exact variables are key in order to understand the risk of a certain patient. So as soon as the physician goes and sees the patient and they click this button, it'll tell you the chances of this person having a heart attack in the next 7 days is 0.003%. So forget about workup. Just send them home, right? I mean, we would save a ton of money if we didn't observe, do every 3 hours or every 6 hours troponins, observation and hospitalization. If we just use that data, so that's where I think the electronic health record, although not the kind that we see right now, I call it a dumb record. We want a smart record, which can actually help a physician, right? Current systems, if you see 100 patient and if you see 1,000 patient, it doesn't change. It's the same thing over and over and over again. And how does that patient number 101 is different from patient 1? How is the care different? Because you have collected so much data on these patients. And that's where I think, the value is. Trying to design that kind of an EHR where it is so smart that it can collect the variables only the variables that you really need to assess the situation.
It's almost like it's system focused. It benefits doctors and it benefits patients.
Those are the only two people that are most important in a healthcare system. Everybody else, it doesn't matter, right?
So I've got a question for you about artificial intelligence. So
sure.
The computer can look at so many data points. And the way I understand machine learning is it can't exactly tell you why it's making the decision that it's making. And I think doctors find a hard time. I mean, I've flown with doctors before that they're rather white knuckle flyers in that they get very nervous about what's happening. And I think it's because they're not in control. How do doctors turn over control to the machines when the machines can tell you things that are accurate, but they can't necessarily tell you why they're accurate?
Well, the technology keeps improving. Right now there is explainable AI, where it can explain you why. The question is, will you know about it? Will you understand it? it can give you, a 100-page report why it made that decision. So here is the key. When you design a tool, when you design a technology tool that you're going to use with your EHR, make sure that it is like any other tool. It is like a drug or a device or or any kind of intervention, and test it. So test it, run a clinical trial, have a control arm, have an intervention arm, and see what happens. Because these are powerful tools, right? And we don't want to just blindly follow them. We want to test them, and that's what we did. Half of the emergency departments had this tool, half controls, and we collected data over a year or more to see what happens. And it'll clearly show if it is a good tool, whether it is better or not than the current status. So that solves the problem, right? I mean, when the drugs come into the market, we don't know the exact molecular structure of that drug. But if it does well in a clinical trial, we believe that it is doing something good. And the other thing is you got to keep monitoring your population. You have to keep watching to see how it is affecting, because you need to tweak it once you go through the cycle.
It's sort of like the way I feel about my iPhone. I mean, I get whatever up, it works. I don't necessarily know how it works, but it's very convenient. And when there's an update, I do whatever update, and we just move forward.
Yeah, but it's a little bit different if your iPhone just suddenly told you that this patient is, and it's really the holy grail. The iPhone tells you this patient's going to get admitted to the hospital in the next 24 hours, but because it's running in the background, but it can't tell you exactly why it knows the patient's going to get admitted. It's just a little bit different. Yeah.
Here's a good example of how it can predict. So we did a study. We worked with the FDA and looked at 30 million EHR records. 30 million. So we got good longitudinal data, and out of those, we picked the patients who had COVID and survived. So the idea is to look at COVID patients. What happens to these patients? How do they fare? As far as outcomes are concerned, after they have recovered from COVID. And we found that there is a very high incidence of cardiovascular mortality and morbidity. Strokes are higher, MIs are higher, DVTs are higher, and PEs are higher. And we could also see that patients who are on anticoagulants for some other reason, they did much better. And so, I mean, that's a gold mine to understand. Oh, okay, maybe we should put all these patients. What is the risk of having a bad outcome with a clot, right? And so we can immediately start putting interventions, or at least clinical trials, to make sure that interventions work. And that's how you save patients, using data. And I think that's a great example of how you can modify your treatment plans based on the data.
It's taking the EHR data to a whole different level, what you're doing there, and the ability to be able to look at tens of millions of records so efficiently like that. I mean, I don't know any other way to do it other than using the data in that manner.
And imagine, for example, ChenMed, right? You're looking at bad outcomes and how to control the costs and how to make sure patients get quality care. What if you could, and by the way, that FDA system, the area under the curve was 95%. It's so good that it can, predict so well, in the next 3 months, 6 months, 1 year. But what I'm saying is, let's say if ChenMed had that kind of a system, right? You can predict when your patient is going to have a bad outcome, and you can actually change the direction, change the path, so that they stay healthier longer. That's very valuable. That's very valuable for the patients and also for the physicians to be able to see that.
Right.
It's true.
I would agree. So Dr. and I might mess up his name, Dr. Agarwal brought up an interesting question: is how to make competing systems adapt to these new database management, because it might go against the fee-for-service world. I mean, I often wonder, I can have an account with Wells Fargo and an account with E-Trade, and Quicken can pull it all into one place, right? Or Mint or whatever, aggregator I want to use. But if I go to a doctor, two doctors associated with two different hospital systems, one doctor can't see what the other doctor is doing, and it's my information. I don't quite understand why that's happening. Why do you think it's happening?
I think our leadership needs that political will to make it happen. There's no reason why you cannot, and there is some movement in that direction where, the data will be shared, between different entities. But let me that's a good point. What Dr. Agarwal is asking is that how do they compete? Now, if you had, let's say you have these full risk models, right? And if one full risk model is competing with another full risk model, you would compete on outcomes, right? And the best outcomes are from the best technology, obviously, right? And but you cannot do that with fee for service. It's because the business model is exactly opposite. And that's why it is so hard for any data-based intervention to take root and to actually change the direction of care in a fee-for-service model. What if I go to a hospital and say, hey, I'm going to decrease your heart attack rates by 10% in the next 2 years.
Yeah, I mean,
get out of here. I need heads in the beds.
Yeah, that's right. That's right.
I can't do that.
Suddenly you have practices, if they were all in the non-fee-for-service world, like say with flu vaccines, could you imagine primary care offices competing against each other, seeing who has higher flu vaccination rates to prevent all the flu admissions?
Exactly. So that will never happen. And that's why all these regulations and the reporting, it's all very artificial, and that's why physicians feel the stress, because it doesn't matter, right? They're being forced to do things that actually are not affecting the outcomes for the patient. And you'll be surprised, when physicians say, I'm not going to use that technology, I'm not going to use that tool. What it means is that the tool, there's something wrong with the tool. Either it is not doing what it's supposed to do, and physicians are very good at picking what works and what doesn't work. And so a lot of the technologists think that physicians are old-fashioned, but they know exactly what works and what doesn't work. That's right. If you bring something that really makes a difference for the patients, they will use it. They will use it. Especially if you can tie reimbursement to it.
Well, many doctors, so far as work is concerned, many doctors feel that regardless of whatever EHR they're using, that the EHRs add hours of work to already their very, very busy days. So for the doctors who are stuck, we have, I think, what's the number now? Over 70% of American doctors work for a hospital, are employed by a hospital system or something along those lines. Yeah. They're employed. So what are some steps that here you got great doctors, but they're stuck in the system. They're spending hours extra every day because they have to use this EHR system. What are some steps that they can take, especially for these doctors who are employed by hospital systems, they're stuck with the CHR. What's some steps that they can take to help reduce some of that daily burden? I mean, when you're talking about hours of just doing technical work or clerical work, what can they do?
Oh God. Unfortunately, they can't do anything. They just have to get off the treadmill. Get off the treadmill. There's no reason why, they cannot join a group which is, more value-based care. There's no reason why they can start their own practice if they're so inclined, like a DPC. There's no reason why they cannot join a group like yours, ChenMed, and as it grows. There's no winning at all, and it's going to get worse and worse, as so whenever we start to reimburse something, and I'm sure you must start reimbursing something, that usage goes up. So the more and more of those procedures, more and more of that, whatever they're being reimbursed for, and then the payers will start to decrease the amount they pay. They'll keep pushing it until the usage goes down, and that's not the right way to practice medicine. If a patient really needs it, he needs it or she needs it. But if the patient doesn't need it, they don't need it. But that's not what is deciding here. How much they get paid for what procedure is what is deciding. Same thing. When people say, "Oh, RPM," you get paid, you get reimbursed for that. But really, I mean, where is it actually helping? Right? What use cases? What specific use cases where it is improving patient outcomes? And of course, you should fully reimburse that. But in cases where it's not, you don't need to. You don't need to do that procedure or that intervention because it's not going to change a patient's outcome. So you're wasting a lot of time and money. And of course, physicians have to do it because, otherwise their income goes down. And it's a very, very difficult situation there.
There's very little, if anything at all, as long as CPTs and RVUs are involved. That's what it sounds like.
Exactly.
Yeah. It would be a wild idea to pay to keep people healthy and out of the hospital, right? Rather than paying to do things.
It is a wild idea. And I really admire pioneers like ChenMed and others that are pushing that envelope, where it's doable, and that's what it's supposed to be, right? Science is supposed to help keep people healthy, but we kind of corrupted the system, I think.
And the story with ChenMed, little known fact that we're expanding. There's a lot of growth happening now, but this is 36 years in the making. So it took a long time to get to this point where we're able to scale. Yeah. But now that we've gotten here, there's nothing stopping us, literally.
Yes, the same thing happened, with Kaiser. They've been in business for 70 years with that same business model, which is prepaid healthcare. And now they are being recognized as a leader in the quality and also patient satisfaction and things like that. But that's what it takes, and it's a big problem to solve, but it is happening.
Thank you, Dr. Chettipally. I'd like to take a quick 20-second break here for a commercial, and when we come back, we have a couple more questions for Dr. Chettipally about some of the fluff in the chart, as well as trying to restore the doctor-patient relationship as best as you can with the current system. So we'll be back in about 20 seconds.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. So Dr. Chettipally, we have a huge number of doctors, like you said earlier, burnt out by the fee-for-service system. I believe it's a result of everything that comes with the stress of billing, like you had mentioned, all the justification with the fluff in the charts. as well as all the reactive practice culture that comes with that. So what are some steps that doctors can take in that model and dealing with everything that comes with the EHR and that culture to help shift some of the focus towards prevention and earlier intervention, even if it's not efficient?
Yeah. So actually, COVID has really brought this thing into focus, right? You know, the outcomes for patients who have chronic conditions, and 80% of the chronic conditions are preventable. You know, the diabetes, the hypertension, the high cholesterol, and all those things that we know. We know that these patients will have bad outcomes with COVID. So we are seeing higher death rates, higher ICU admissions, and higher morbidity in these patients. And we know the value of the vaccine now that it is out there. Especially the physicians, they know the value of vaccine, and that's why there's all this push to vaccinate as many people as we can. Now imagine if that vaccine is just trying to control their blood pressure or trying to control their hemoglobin A1C or their cholesterol. That is as effective as a vaccine, because now you're taking this high-risk group and putting them into a lower risk group. So, right? So you're shifting the whole focus. So for primary care, I would say that pay very close attention to these risk factors when they come up, because that's what is going to change the outcomes from many other conditions. That's number one. Number two, when primary care physicians also have this onus that they are the ones that have to educate the public about the benefits of vaccination, right? And they are the ones that have to change that perception, because nobody else, they would. Hopefully, the patients still trust their primary care doctors. And so not only educate about the vaccinations, but also all the other preventive things that they need to be doing, whether it is, getting a stool test, for colon cancer, or getting a mammogram and things like that. So make that, I would say physicians need to make that a priority. The first thing they do should be that make sure all the things that the preventive measures that are supposed to be happening on a particular patients happen in a timely manner. And then as you talk about these things, patients will start to understand. It's our job to educate. Nobody else will educate them, because we are the ones that have taken an oath to keep these patients healthy and to make sure that their health is our concern. And so we have taken up this responsibility. So I would say physicians need to do a better job of outlining these preventive steps that patients can take. And patients are willing to listen. If not 100%, maybe 70% are willing to listen. Right?
Well, I think part of what we have going on now is that you have decades now of just doctors being less and less engaged with the patients and more engaged with the computer. And the patients are feeling that. So even though the doctor may be sitting in the same room as them for 10 minutes, 15 minutes, but their minds couldn't be further apart. So they're sitting in the same room with the patient, and even in fact, we give a lot of residency lectures, so we're engaging and connecting with a lot of residents, and we're even learning and hearing about doctors. They don't even put a stethoscope on their patient. They're not even touching the patient. They're so focused on the computer that they're not even touching the patient. And so, what can doctors do to improve or increase at least the doctor-patient engagement time? I get it that there's work that has to be done in the computer. They got to justify, the time spent and get the reimbursement back. But what are some things that doctors can do to help increase the doctor-patient engagement time?
Yeah, I would say, have a good talk with your leadership, because it's the leadership's responsibility to make sure that their physicians are happy doing the work that they're doing. The physicians are not stressed out, doing the work that they're doing. So, there's a lot of, ways that you can unburden the physicians. Take away all the things that they don't necessarily have to do it themselves. Whether it is, if it is transcriptions that you need, or if it is, a technology that you need that can transcribe, or things that can be taken out of the physician's hands so that they can practice at the top of their license, right? They're making the big decisions rather than the small ones. And so have them adequately staffed with ancillary staff so that, their job gets easier. A lot of times, you just throw the physician into this clinic and then they're supposed to swim and figure out things. Let them have a lot of support staff. Let them have the help that they need. And that's where the leadership comes in.
Unfortunately, we don't see too much physician leadership in the healthcare world. We have too many non-physician administrators, and perhaps this is the time for doctors to start taking more of a leadership role
Exactly.
in healthcare.
They need to speak up, and they need to come up with ideas, and that's what we help physicians bringing innovation to the world. At Innovator MD, that's my company. We have physicians who have these ideas, and how do we help them? How can they find partners? How can they find potential customers? How can they find potential investors in what they're doing, bringing these ideas to life? Because physicians see the problems up front, right? They are the ones in the front lines, and they see these problems every day, and they're some of the smartest people that we know of in the healthcare chain, right? And they can come up with some brilliant solutions. So, I would say support the physician innovators, because that will pay off in a big way.
I agree with you completely. Perhaps it's going to take like revolutionary payment reform for there to be aligned incentives for people to work with each other to help improve the lives of doctors, help improve, of course, the lives of patients, and just really improve the health of the country.
Yes.
Well, Dr. Chettipally, thank you so much for joining us tonight. This was just a great conversation. This is our second time having you on the show, and this was just great. I really enjoyed myself. Dr. Dan, what a great evening.
Absolutely. I thought this was a very interesting conversation and lots of hope for the future.
And to our audience members, thank you so much for joining us tonight. We enjoy the chat. We enjoy the questions and the comments. And for more information about today's topic and to explore career opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.
Thank you.